Continuous quality improvement in Nigeria did improve PMTCT services, cut waiting times and significantly boost the morale and motivation of healthcare workers.
Before, we are tired. Everybody said the clients are angry, we are angry. There's always one or two complaints. But now, as you can see, we had a very, very cool environment. We work at ease, there is no problem.
But the intervention showed no improvement in retention. Special HIV-positive mother-infant clinics in Malawi led to some improvements, but the project was plagued by staff shortages and lack of space.
The biggest lesson in this study was that even simple interventions require a strong health system. If you don't have enough human resources, if you don't have enough space, that's going to limit the level to which you can implement those integrated services.
The integrated clinics had no impact on retention. The SMS tracing service also had no impact. Overworked healthcare workers often failed to send the messages. However, when reminder messages did arrive, data shows that mothers usually responded and went to the health centre, so maybe it's a model worth exploring further. The enhanced counselling around CD4 tests in Zimbabwe did provide good education about HIV, but this did not translate into better retention.
What we identified is that there are complex factors related to family and also community that need to be looked at in such interventions, and our study did not address some of that.
Peer support groups in Zimbabwe were very popular with participants and showed a small, although not statistically significant, improvement in retention. Staff and participants say the most vulnerable women who would have benefited the most often did not attend because they were unable to disclose to their husbands.
It is very difficult to go to the support group if you have not told your husband and your relatives. The day you are going, everyone wants to know what you're going to do.
The use of mentor mothers in a randomised controlled trial in Malawi showed a dramatic and significant improvement in retention. A similar trial in Nigeria showed that training, supervising, supporting and professionalising mentor mothers gives much better results when compared to a regular mentor mother programme. The best result of all was achieved by expert mothers in Malawi. This is all good evidence from large randomised controlled trials, but researchers say the mentor-expert mother intervention is multifaceted. The mothers counselled, provided peer support, organised support groups, did defaulter tracing, home visits and family counselling. The close supervision also led to health centre improvements.
Although we have shown with our results that peer support is beneficial in retaining mothers, we don't really know which aspects of the different interventions were most effective. Whether it was the one-to-one contact that mothers had, or it was the home visits or the support groups. So this is the next step. We now need to find out which is the most efficient way.
Mentor mothers themselves consistently said that failure to disclose to husbands was the most common barrier to retention, which they struggled with. At this health centre, expert mothers only managed to get the husbands of 11 of the 44 women they enrolled to be tested. In only one health centre was there 90% male attendance, and that was because village chiefs made it mandatory for all men to go to antenatal sessions. To address the problem of male involvement, the organisations implementing the study have started to hire HIV-positive men to work alongside the mentor and expert mothers. Meet the male motivators, another idea for improving retention.